upload. Okay, so as long as we've lost probably 3 or 4 seminars because of the midterms, as always, we have to go fast. So I'm explaining the thyroid pathology today. The thyroid pathology is like 14 to 13 pages, so I'm going to divide it. We're going to start with all the pathology except tumors, and we're going to do the tumors next day. Okay? Because it is extremely important to know thyroid function and pathology very well. So, guys, have you watched the video I have uploaded? So the basic, some kind of overview of the hormones and stuff. Okay. So you actually have to know what TSH is, right? TSH is the thyroid stimulating hormone, which is produced by the pituitary gland, anterior pituitary gland, which stimulates the thyroid gland. Okay, before I get to the thyroid functions, I want to do just a little bit of anatomy. Thyroid gland is a superficial gland, which is immediately below the skin and the fascia. It's very superficial. It's right there. You can palpate it very easily. I'm going to actually teach you how to afterwards. So there is the trachea, and the biggest cartilage of the trachea is the thyroid cartilage, which sometimes is called an Adam's apple, which grows in males. So sometimes males have like bigger thyroid cartilage. After the thyroid cartilage comes the cricoid cartilage, and there's actually a gap between the thyroid and the cricoid cartilage, which is filled with a thyrocricoid membrane, and that's the place where you do the emergency cricothyroidotomy whenever there's obstruction of the airway and you need to establish a new airway. So you go with a knife, you cut that membrane and put the tube in there.
It will be in the second ring? Maybe.
Yeah, so between the thyroid and the cricoid. It's easy to palpate. Thyroid is right there, so you can palpate it pretty easily. It has like triangular shape like that, so you can palpate it easily. And when you go down that, you're gonna feel one like hard ring like that. And between those two, you can feel some kind of a space. So you palpate that in the person, get a knife, get in there, and then put the tube. Okay? Yeah.
They said I can go.
Who said?
I have my name.
You can go. If you want to go, you can go.
No, sir. In the exam, they said pass. And you can
Oh, so you get the pass?
no, they said I pass, so you can go. Before.
So you get 10. Do you want to repass? Yeah?
I was in between.
You should go to the TICOS then and tell her, because she said that it's okay if you retake it. So you can go now to TICOS and tell her that. But she got 9.5. You cannot retake it. You got 11. No.
11.
Yeah, you got 17. It's up to you. Okay, so below the cricoid cartilage, there's the thyroid gland. So whenever you go, you feel the cricoid, you go a bit down, and you feel that there is something softer than the hard cricoid there. So that's something softer is thyroid. Some guys have it like a bit low, some guys have it right there. But you actually feel that it's something like around the thyroid. It's easier maybe to palpate it from behind. So sometimes people do it like that. So doctor stands from the behind and just palpates it like that. Well, we're going to do it like, let me finish this first. So the thing is that embryologically, thyroid gland first develops in the, like on the tongue, very close to the tongue. Then it descends down and gets there. But it has a special ligament here, which at first is a duct. It's an open duct which is drained, like the fluid is drained up to the tongue. And actually there's an opening at the tongue, at the base of the tongue, which is called the foramen cecum, And that foramen cecum is the like closed actual opening of the duct. So the thing is that during the descending, sometimes the thyroid may stop here, here. It's okay. It's not really okay, but still. It's called an ectopic thyroid. And sometimes there's some part of the tissue stays on the way, somewhere on the way. Usually it's in the tongue. There might be small tissue in the tongue. It doesn't make any problems unless there's a tumor development there. And sometimes the duct doesn't close fully and may develop a cyst like that, which is filled with fluid. It's very easy to palpate. And it's called the thyroglossal cyst because the duct is called thyroglossal duct, which is glossus means the tongue. Okay, that's kind of it. If we look at the thyroid has usually two lobes, left and the right lobe, and the middle part which it connects, and it's called an isthmus. And sometimes in 20 to 25% of the population, it has also a third small part, which is called pyramidal lobe. Yep. And actually, this is the continuation of the thyroglossal duct. Okay? Okay, but it's not always there. For the blood, let me also give you a blood supply. It has like usually 2 or 3 arteries going like that. But there's always superior and inferior, like inferior and superior thyroid arteries. Sometimes there's also a middle one. And thyroid ima artery sometimes also supplies it from the below, from the aorta or the subclavian artery. Sometimes. Actually, the inferior and superior thyroid arteries are the parts of the jugular arteries. There are 10 carotid arteries. Okay. Yeah. So the veins are the same, superior inferior veins, and sometimes there might be ima vein also, which is connected to the like subclavian vein. Okay. So now let's move to the 2 main types of diseases, not disease, but the manifestations of the thyroid disease. So the endocrinology works like that. It's like easy in a way of understanding because you've got a hormonal control, which is always in some kind of a regulated, and all the hormones are on the levels that you need them to be. So in the endocrinology, there are 2 ways. Either there are a lot of hormones, so high level of hormones, and it creates problems, or there is a low level of hormones, and it also creates problems. So every gland is going to function like that. Every gland's pathology is going to be like that. So the thing I want you to understand is that the clinical manifestations and the symptoms almost always, okay, come from the level of the hormones. So the hormones of the thyroid cause either deficiency problems or excess problems, not the hormones of the pituitary. So you cannot actually know by symptoms if there's high pituitary hormone level or low pituitary hormone level. You should test it. You should do the test for that. But you can know if there's a high like thyroid hormone or low thyroid hormone or high adrenal hormone or any high or low hormone of any peripheral gland, but not the pituitary. The only time you can know if there's a high pituitary hormone or not is TSH sometimes goes to special signs, which the TSH does itself, or ACTH sometimes gives the specific symptom. But usually it's the peripheral hormone. So the thing is, every time you see a symptom or a complex of symptoms which is characteristic to the high or low hormones, you should test that hormone and plus the stimulating hormone of that gland of the pituitary. So for example, I see the guy who has the symptoms of the high T3, T4, I do the test for T3, T4, and I also do the TSH. Because without doing the TSH, I'm going to confirm that there's high T3 or T4, but I'm not going to be able to understand why. So if I do the TSH, I'm gonna know
Will be
why.
less.
What?
Time TSH will be less if we have
Depends. So now let's go to the different signs and symptoms of the high and low T, like T3, T4, and then I'm going to just develop that even more. Okay, what's the function of the T3 and T4? Before we get to the function, there's actually the, what's the biochemistry? The TSH is actually made from tyrosine. So, not TSH, sorry, T3 and T4. And it's like there's the COO group, there's the NH3 group, and probably there should be one CH2 there. If I remember, I'm not really sure about that, but still, it should be like that, tyrosine. So, there's a benzoate. Yeah, okay. So, the thing is, this is probably it's a tyrosine. I don't remember right if there's maybe two CH2s, so I don't remember. But the main thing is the ring. So imagine that the thyroid gland takes that tyrosine and attaches the iodines to that. One iodine here, one iodine here, one iodine here. So this is the T3, 3-iodo-tyrosine. T4 will be that. Okay? Thing is that T3 is 10 times potent, 10 times more reaction to the T3 with the receptor than the T4. And you produce 95% of T4 and 5% of T3, or 90 to 10. And the thing is that, so you have a lot of thyroxine level in your blood, but you use only small amount of that in a way of T3. When the T3 is used, the what is left of like T4, part of it then is converted to the T3, and so you use up the time by time, okay? And, okay, that's it. So now let's get to here. So, what's the function of the T3 and T4? The main thing of what the T3 and T4 thyroid does is that regulate the metabolism, the rate of metabolism. And I mean every type of the rate of every type of metabolism. Okay? Everything that we do is regulated by the TSH, like T3 and T4. On the gene level, what it does it gets into the cell, activates the special receptors on the nucleus, and actually starts the gene transcription and translation, so activates the production of the different enzymes. Okay, so it works on the gene level. Okay, so now let's just think about what would the increased amount of T3 and T4 cause. So, increased metabolism. What is increased metabolism? First, every type of metabolism is associated with the energy production and energy release. So we use ATP when we have the increased metabolism. Yeah? In metabolism, in here I mean catabolism. So I use much more energy than I need to. Okay? So I use a lot of ATP, and during using the ATP, in every type of producing, like in the physics, producing the movement or the work, I always produce the work with an energy, but I always produce the heat with an energy, right? So the same thing with the cars, the computer. That's why computers need the fan, and so on and so on. The super phones always get hot when there's like working a lot, and so on and so on. You play a super video game, your computer gets hotter, and so on and so on. So every time you make more work, you produce more heat. So in here, these guys are always hot. So the thing is, they are, if we say it in a cool medical words, heat intolerant. What does the heat intolerant mean? Intolerance means that you cannot tolerate the heat. You're not okay with the heat. And I'm going to tell you why. If you have the thyrotoxicosis, so-called, which means that there's toxic state caused by thyroid hormones, thyrotoxicosis, if you have that, you are always hot. You're always very warm. Your skin is very warm, it's always red, and you actually, when somebody touches you, you're very hot. Actually, you don't need to be touched. When they get close to you, you just like are hot around. Even the air around is hot. So, if it's a winter, it's cool. you never get cold. You don't feel cold at all. But when you get to the summer, it's terrible. Because it's hot around, you're hot yourself, it's terrible. So these guys are heat intolerant because they feel very bad whenever there's hot around. Okay? Same thing, if we move here. If you don't have T3 and T4, you have low amount of it, you have the very low metabolism, low heat production, so you're actually cold intolerant now. So if it's winter, you're extremely cold. If it's summer, you feel okay. Actually, it's good for you. You get like hotter, like warmer. How's it going?
They strictly said no.
Cool. So next thing is that because my heart gets stimulated all the time, much more than it needs to be, there's an increased cardiac output, which is mainly because of tachycardia. So I have tachycardia. And much more important than tachycardia is palpitations. Now, tachycardia is always present there. But the problem with the tachycardia is that you don't know you have a tachycardia. Unless you measure your pulse, you don't know it. Right? But what is palpitation? Palpitation is the feeling of having the heartbeat. So somebody's coming to you telling you, doctor, I feel my heartbeat all the time. So then you measure the pulse, there's tachycardia. Palpitation is a special sign of something's going on with the heart. Usually there can be not a sinus rhythm or maybe arrhythmias cause palpitations a lot. So if you move here, these guys are going to have bradycardia. But bradycardia during T3, T4 is much less common than tachycardia in T3, in the excess amount of T3. So tachycardia will always be there. Bradycardia cannot, maybe not always. It's common, but not always. Okay? Because usually, if there's a bradycardia, my sympathetic tone starts to regulate that. And during the T3, T4, sympathetic tone is also increased. So because of that, because the T3 and T4 are high, and my sympathetic tone is always high, and sympathetic tone actually what it does do, it prepares me for fight and flight, so I'm always active, I'm always ready to run, jump, and so on and so on. So I never rest. So if I don't rest, and I'm always activated, I have insomnia. I cannot sleep.
Insomnia.
So these guys have insomnia, the difficulty sleeping, bad sleep, sometimes even bad dreams, and plus they don't get tired. They're always energetic because they use all the energy they can get. And sometimes they're so energetic they can get aggressive. They talk fast, they sometimes talk with a high voice, they're all activated, agitated, and it's not their fault, it's all the TSH doing that, T3 and T4 doing that. And vice versa with the with the low amount of T3, T4, these guys are always sleepy. They can sleep for a whole day, especially if it's serious deficiency. Sometimes they just sleep and don't wake up unless you wake them up by force. They're very sleepy, they're very weak, they have the weakness, not energetic at all, they don't want to do anything, they don't want to go to the job, to the work, they don't want to do absolutely anything. And in students, I want you to remember that the studying just goes extremely low. they can study anything. I had the friend who developed the hyperthyroidism, and because of hyperthyroidism, she was one of the best students in the year, and on the next year she was like in the group 3 getting all the zeros. Yeah. So it's actually has a lot of things to do with the study and like all the neural work that you do. So what else? Oh,
Diarrhea.
very important. What?
Diarrhea and
Diarrhea in here. Now, why diarrhea? It actually is a bit strange, and actually it's still strange for me, because sympathetic activation causes the peristalsis and the digestion to stop. The peristalsis and the digestion is the function of the parasympathetic system. But the thing is, T3 and T4 are so much that it overrides all the sympathetic tone on the GI system and still causes a lot of GI function. Metabolism is so increased that the sympathetic cannot actually stop it. So there's diarrhea here, and in here, either there's constipation or there's nothing, because parasympathetic still can regulate it. Okay? So now, one more very important thing in the hyperthyroidism is that, forgot, this is the actually excess amount of T3 is called hyperthyroidism, that's called hypothyroidism. Right? So, one more very important thing is because I used so much energy, I need to eat a lot. Yeah. Right? So there's increased eating, a lot of eating. And despite that much of eating, they still lose weight. Because that amount of eating is still not enough for the energy, so they lose the weight because they use all the weight they have.
Because of diarrhea?
No. Might be because of diarrhea also, but main thing is actually using all the fat you have as an energy. Then when you just use all the fat, then you go to the proteins and muscle mass. So these guys lose their weight a lot. So weight loss. So what are the main things you're gonna see in the patients? Why do they come to you? They don't realize they're aggressive. They don't realize they can't sleep and they're all activated. They just don't realize that. What they realize is the weight loss. They come to you in a month, I lost 5 kilograms.
And heat tolerance, maybe they can.
And main thing is that heat tolerance and palpitations. Sometimes maybe insomnia. Okay? So then you should go further and ask them, look at them, see their skin, if it's warm, if it's all the way, warm and energetic. If they're energetic, if they're aggressive, you're gonna see, you're gonna evaluate their talking and so on and so on. So okay, sometimes they have a specific case. Diaphoresis, yeah, of course. Diaphoresis is excessive sweating. They're hot, they have excessive sweating just because they are hot, and also they have excessive sweating because their sympathetic tone is always up. So that's what the sympathetic tone does, excessive sweating. Okay, so now let's go here, and the thing is that these guys don't really want to eat that much, because they don't use energy at all, but they still gain weight very fast. So these guys have the weight gain. And the weight gain is a specific weight gain. And I want you to remember that. There are two types of weight gain during hypothyroidism. One is the normal weight gain, a real weight, a real adipose tissue fat weight gain, but there's also swelling all around the skin. Plus, there's a swelling. So, during the hypothyroidism, there's an accumulation of some kind of a jelly type of fluid in the subcutaneous tissues. Okay, so they actually look swollen. They look like there's a swelling of the eyelids. There's edema on the face. The face actually changes the shape. If they have like long, slender face, the face becomes round. So it's like
buffing of the eyes.
And the buffing of the eyes and so on. Everything gets swollen, especially legs, and then comes to the.
But in the hyper will be only the lower extremity.
Yeah, in the hyper, there's only actually not the lower extremities, only the shins.
Yes.
So that's a special thing. That's actually called the myxedema. But myxedema is not always during the hyper. It's usually in the Graves' disease. So we're gonna get there. Okay. So I'm talking about those ones because these are the symptoms that you're gonna see during a lot of different diseases. So every disease we study after that, I'm gonna tell you that this disease manifests as hyper or this disease manifests as hypo, and the symptoms will be very same. So then you're going to go and look for the reason. Okay, so...
Doctor, in the hyper, we can see the iodine uptaking is generalized. I mean, in all T3.
Okay.
In TS, it will be localized, like small amount.
Iodine uptake also depends on a lot of things, but whenever there's a special test that is called a scintigraphy. What the scintigraphy does is that it takes a special type of image. You give any type of the gland, doesn't matter which gland. You give their product, not the product, but the compounds they need to produce the product. So for the thyroid gland, you give iodine, and the iodine actually is the special iodine which is radioactive, and it lights up the places where it is used the most.
If it is hyper, will be hot.
If it's hyper, then all the thyroid will light up. If there's a special node which produces more, the thyroid will light up, but that node will be like more like light. So it's called the hot node. Sometimes there are cold nodes which don't light up. We're gonna get there when we go to the tumors. But the thing is that I want you to realize what's the connection between TSH and T3 and T4. So why do you need to do TSH every time you check for T3 and T4? Because the causal agents, the first cause of the excess or low amount of T3 and T4 can be two things. Either my thyroid gland just became crazy and just decided to make a lot of T3 and T4, just like that. Now, because I make a lot of T3 and T4, my pituitary realizes that, oops, I'm making a lot of T3 and T4, so I have to, shut down the TSH, so my T3 and T4 is gonna go low. So if it's because the thyroid gland, then the TSH will be low. So if you see high T3, T4, low TSH, it means that pituitary is normal, thinks normal, but the thyroid doesn't. So there's a problem in the thyroid. It usually is called the secondary hyperthyroidism because primary guide is the pituitary, secondary guide is the thyroid. If thyroid is okay, and what thyroid does, it only obeys the commands if it's okay. So now maybe the pituitary got crazy and started producing a lot of TSH. And because it produces a lot of TSH, thyroid has only one choice to respond to the high TSH and produce a lot of T3 and T4. So if it's because of the pituitary, TSH will be high, and because TSH is high, T3 and T4 will be high.
And doctor, if it's because autoimmunity, sometimes antibody like TSH also releases.
There are different autoimmune diseases, and sometimes antibodies just kill the thyroid. Sometimes during the Graves' disease, antibody looks exactly like TSH and works as a TSH, so activates the thyroid. Yeah, but the thing is, if there's the high antibody, TSH pituitary realizes that the TSH goes down because there's high something that
No
looks like
feedback.
TSH.
Feedback will be.
Feedback will be working. Feedback is working during the. Let me get there. So one more time. If it's because of thyroid, the TSH is low. If it's because of pituitary, TSH is high. And if you remember, if you have read the pituitary part, there was like hyperproduction and hypoproduction of the pituitary hormones. And in the thyroid, it said that if there's a hyperproduction of TSH, then the thyroid function will be high. If there's a hypoproduction of the thyroid, TSH, thyroid function will be low. And now we get to the thyroid function. Okay, same thing is going to be here. If it's because the thyroid is dead and just cannot do anything else, pituitary says, oh, now I need to produce more TSH to get the thyroid function back to the normal. But because the thyroid just doesn't function, doesn't matter how much TSH you produce, there's no response from the thyroid. So it produces and produces and produces. So if it's because the thyroid, TSH gets up. But if it's because the pituitary and it doesn't produce TSH at all, thyroid cannot do anything. So it doesn't produce the hormones. So because the pituitary, TSH will be also. So in easy words, if both are high or both are low, it's because of pituitary. If one is high, one is low, one is low, one is high. So if two glands become like inversely proportional to each other, then it's because of thyroid. If both of them are either high or low, it's because of pituitary. Okay, so now let's kind of get to the diseases. And the first thing I'm going to talk about let's get to the autoimmune diseases. There are 3 types of thyroiditis, inflammation of the thyroid. Okay, there are lots of different thyroiditis, but we're going to discuss like 3. The main guy is Hashimoto. Hashimoto, which is not a motorcycle company at all. It's the guy who discovered the that inflammation, and it's pretty logical why this is Hashimoto and not the Smith or something Bauer, I don't know. Why is this guy Japanese? Just because the thyroid diseases just became very prominent after the nuclear war. So after Hiroshima and Nagasaki nuclear bombing, all the Japan is very in Japan the level of the thyroid disease are extremely high. So I just want you to remember that the radiation is one of the most important causal agents of the thyroid problems. It's as the